All right. Welcome back in, everyone. You are on with Ask Nurse Kima and Charge Nurse Keisha. We're bringing you our third episode, Nurses Notes by way of health and hustle.
Boom.
Yes, we are here. So today we have a very special guest with us, my personal PCP, Direct Primary Care, Dr. Michelle Cooke of Soul Direct Primary Care.
Well, Happy New Year, Nurse Kima.
Happy New Year, friend. How are you?
I'm doing fine. Girl, listen, I done started out the new year with a bang, girl. I started doing my vision board, although I didn't start until the second, but it's done. My vision board is done. Girl, I wrote down some goals, some things that I want to pay closer attention to in this upcoming year that I wanted to share with you. And
Yeah.
then I wanted to ask you yours. And I wrote mine down. Okay.
Okay. Okay. I'm with you. 2025 is our year, friend. It's our year.
Yes. And girl, like it's already starting off with a bang. So I'm trying to refocus. So I wrote some things down. And so let me just share them. Okay. So the first thing is five things that I wrote down. The first thing that I want to do in the new year or during the year is strengthen my body. I feel like since I've been on my weight loss journey, I'm not as strong as I should be. So that's one of the things I wanted to do was pay closer attention to increasing my endurance and toning up my body a little bit more. Number two, I want to be more intentional in my relationships because as a woman who wears many hats, honey, I be all over the place.
Yes.
Sometimes I'm not as intentional as I should be. So I really want to work on that. Definitely want to strengthen my relationship with God. I should have said that first. Because, honey, if it
Without
were the
him.
time that I need him, Lord knows,
Amen.
I need you.
First and foremost,
Um,
giving honor
yes.
to the church.
And then another thing that I want to pay close attention to this year is I want to spend more personal time with my husband and my daughter. Y'all know I have a 21-year-old friend, and it's some things you go through, that separation anxiety is real strong in our household. My daughter coming from adolescence to young adulthood, it's a lot of letting go that me and my husband have to do. So feel the best way to do it is to stay close to God and spend more time with one another. So definitely want to do that. And then last but not least, I want to spend more time in the moment.
Oh, yes.
Kima, girl, and I tell you, there are a lot of times I have been spending time with people that I love, and my body was there, but my mind was not.
Mhm.
And I want to work on that. I really do. I want to learn how to separate myself from the nurse and from the social media personality and just be the wife, the mother, the daughter, the sister, the friend. So those are the things that I want to work on this upcoming year. What about you, friend? Have you thought about it? I know I saw you and your fiance working on y'all's vision boards. And listen, when I tell you that was the cutest thing I've ever seen, and I needed it. I needed to see that. I needed to see a couple spending time together, sharing your thoughts and what your expectations are, working together. I love that. I needed to see that. So I know that you guys have finished your vision boards, but what are you aspiring to personally for the 2025 year?
So let me just say, I've been doing vision boards for a while now, but I am accustomed to just doing them on my own, by myself, taking that time to just decompress and focus, to be intentional about where I want to see myself in the next year. So I shared my thoughts with him, but never in a million years did I expect him to say, well, I believe we need to do one together. And that was new
Okay.
for me. And it gave us that time for me to hear his thoughts for us versus
Mm-hmm.
my thoughts for us.
I
So,
love that.
the way I was raised, the man leads. And
Mm-hmm.
so I was so eager to hear how he planned for things to be for us in 2025. So I have, of course, thought about the things I would focus on for 2025. And I must say, the first thing is I have to cook more, friend. You know, I'm a DoorDash Uber Eats girl for everything. Honey, just because my portion size is so small, I'm like, oh, I just get something quick. Let me just order. I don't have to leave the house. I work from home. But honey, I have to be more intentional and cook for my
Yes.
family, friend. For real. So that was number one on my list, to be completely honest.
Mhm.
Definitely with the weight loss, I am so weak. The amount of times
Mhm.
I call my honey bunny and my daughter to open up something for me because
Oh gosh.
I'm so weak. So
Mhm.
I'm definitely focusing on strength training and kind of monitoring what I eat to increase the amount of protein that I need in my body to just be a healthier version of myself. So
Yeah.
I have to look that desire, the clothes and all that. But when it comes down to it, am I really as healthy as I need to be?
Mhm.
Am I as strong as I need to be? And I definitely have to piggyback when you say being more intentional,
Mhm.
because I have made a little note to set boundaries for myself. Okay. I am so accustomed to just being that over and beyond person for everyone that I make myself last because
Mhm.
I feel like I need to just keep going, do for my friends, do for whomever that needs something from me. And a lot of times I go so much so that when I finally lay down, I'm out for days.
Mhm.
And that's because I have not put myself first. So I'm going to make myself a priority and
Mhm.
set some boundaries. Definitely going to focus more on my family because my daughter is a teenager. She's watching her mom on social media. And so she's into all the little girly things. And I need to be there to guide her along the way.
Mhm.
But she's getting ready to transition over to high school. And believe it or not, she's ready, but her mother is not.
Time waits for no man. Those kids are growing into their own people.
All right, so pray for me, okay?
Oh God.
Pray my strength in the Lord.
Praying,
I
praying,
need it.
praying, praying, praying.
So that's kind of where I am right now. So, 2025 is going to be great for us both, for sure.
I love that, and I love that we are friends who have come together for a greater purpose, especially for the medical community, not just the GLP-1 community, hence nurses' notes. There are a lot of visions, you and I have talked about them day in and day out about what we want to do in the medical community, not just in the GLP-1 community, because there's such a lack of education, such a lack of inspiration and encouragement for patients. There's a large demographic of patients who need someone to help them understand what is going on in their bodies. So this is one of the reasons why you and I talked about doing nurses notes. We talked about doing nurses notes when we were birthing Health and Hustle. And I love the way that it has come along. It's so funny how God is going to have his way in a situation.
Every time.
It ultimately went back to what we discussed the first time. It brought us right back. We wanted to go in one direction, but God said, no, this is what I told you all to do. I need you to speak to my people. They need help. They're hurting. They're sick. You have the knowledge. I've touched you. My hands are on you. And the expectation is for you to do my will. Okay. And so for me, what I hear is that the community needs clinical direction.
Mhm.
So my hope is to find clinical providers in different specialties to help answer the many questions that you and I get asked almost every time we are educating. There are some questions that under our scope we cannot answer. So my heart wants to find the clinician that can. What are your thoughts?
I'm right there with you. One of the things that I'm really big on and have been for quite some time is empowering the person
Mm,
self to advocate for themselves. So my biggest goal is providing resources for
mm,
others so they know what resources are available or even who to reach out to find out what is available. Because a lot of times we don't know what we don't know, you know.
right.
I'm here to, of course, be that advocate and to point you in the right direction when it comes to taking care of yourselves and having the best quality of life. That is so
Yeah.
important to me because the help is here. It's
Right.
mhm.
Right. And one thing about it, there is access to social media. It's just what do they have access to? So I would hope that we can come together um, and give the community what they need to help them be able to get empowered and start advocating for themselves by way of nurses' notes through Health and Hustle.
Absolutely.
Mhm.
Here for you all. And to all of our followers that are out there, we want you all to engage with Health and Hustle Nurses Notes with myself and charge nurse Keisha. But understand that there are many, 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 many topics that we think of day to day, but we want to hear from you, the topics that are concerning for you, the questions that you have, so that we know that we can provide you with the information that you truly are seeking. Okay.
Mm-hmm.
So make sure that you send all of your comments and questions to our email address, healthandhustlepodcast@gmail.com, friends.
Please, guys, we're waiting for you.
Okay, friends, since we have been talking about finding clinical providers, guess what? We have a treat for you all today. I have my personal provider here with us, Dr. Michelle Cooke, and we posed a few questions to her. Let's just be honest, with Keisha and Kima, we did send her a list of questions, things that we wanted some answers to based on conversations that we have had from our followers. So we're going to get right into that right now. Dr. Michelle Cooke, Soul Direct Primary Care. Cooke, you are here with Ask Nurse Kima and Charge Nurse Keisha with Nurses Notes by way of health and hustle. So welcome.
Yes.
Thank you for having me. I couldn't be more excited today. And you guys know I have to take it a little bit ratchet. I'm sure you get this joke all the time, but I can't be here with Kima, Keisha, and not have Pam. Every time you say your names back to back, I just hear that total song in my head. I was like, how do we have all this lined up? It can't be Kima, Keisha, and Michelle today. It just doesn't work. But one day y'all get a Pam on here and it will just be perfect. I'm so excited.
Absolutely, give it that total effect, okay?
Pretty much. So I'm always a big girl, always carried extra weight, like you, all the yo-yo dieting. I did all the things, all the Weight Watchers, all the keto, all of that. And you get these short-term successes, but nothing ever stuck long-term. And when I saw the weight just continue to tip the scales, I was like, and I can't get it down. I talked to my doctor. And at the time, I was actually on Saxenda. So I started, if you guys remember, it's still around, but not as much degree. The trouble with Saxenda is that it's a daily injection. So you have to
Yes. I took that too, Dr. Cooke.
Yep. So Saxenda, it got me somewhere. Like it did help. I did notice a difference on Saxenda. I had some success on it, and then Ozempic came after that, and I was like, oh, this is even better. And I never stayed on Manjaro for too long. I started to go down that pathway, but then I don't know how much you know about my story, but left my job or was terminated because they were closing our level 1 trauma center and all of the healthcare offices connected to it here in Atlanta. And starting this process of the practice, insurance changed. I didn't have that good insurance, whatever that means anymore. So being able to access the medication became very difficult. So I'm now on compounded semaglutide and it's keeping me maintained. I'm happy. So yes, I do feel like it's something we have to talk about, especially for us, who don't always have access to these medications. We get real suspect when we talk about injecting things.
Yes.
I feel so good about that. So I love that you all have created a platform to make a safe space. Kima knows I'm all about the safe space for Black women. So I love your story and I'm so happy to support you guys.
Thank you so much.
Thank you.
And thank you, Kima. Thank you so much, friend.
That is my pleasure. Please share with us all about Soul Direct Primary Care.
Gotcha. I'm working on making it a snippet, but it's so hard to make something that feels so big in my life into a soundbite. But Soul Direct Primary Care, suffice it to say, it is the sacred space for Black women's health and wellness. So I have the only direct primary care practice here in the Southwest Atlanta or South Metro Atlanta area. And the mission of my practice is to make sure that Black women get highly qualified, highly ethical, highly accessible care. We've been left behind so often, in the healthcare system. All of the mortality rates are worse for us. All of the disparities are hitting us. And we just have not had a safe space for that. I came from kind of traditional, conventional medicine. I used to work for a very large healthcare system, still within the same community. And I was very proud of the work I was doing there. But there was a lot of forces that I just did not have the power to fight that were bigger than us. And the biggest force hit when they actually closed our hospital system, or our hospital system still exists, but they had hospitals in the Black community, a large level 1 trauma center and a secondary community hospital that both collapsed, mainly for funding issues, not enough insurance reimbursement, all those different things. And so our community lost all this care overnight. I was outpatient, like we were in the ambulatory space, we were doing primary care. And the way healthcare is set up nowadays is we don't value primary care. And primary care only stands as much as it can support the hospital, right? So they want our referrals, they want our mammograms, they want our surgeries. Like we feed the hospital, so we have to support them so they can do those big ticket items. But the things that really keeps people alive, a doctor talking to you about your blood pressure, a doctor talking to you about your stress and your mental health, those things we don't value. So when the hospitals closed, they closed all the outpatient centers too and took all the primary care out of this very, very underserved community. So I was called to action. I was like, I can't play the same game that they're playing. And I started my practice. So direct primary care means that there are no middlemen involved. You don't use insurance to access my care, which sounds crazy and revolutionary to a lot of people. Like,
Mhm.
how on earth do you do a practice with no insurance? And the way I describe it is that my members subscribe to the practice. They pay a monthly membership fee, and that gets their appointments with me. They can call me, they can text me. You've been open about it, so hopefully I can share that Nurse Kima is a patient as well. So I've got my text messages, my portal messages from her. I've helped her from afar. I think she's only been to the practice maybe 2 times, but we've had so much contact
Yep.
because I still feel very responsible for her, even when she's not here in the office with me.
Mhm.
So I've been able to give incredible care and get the greedy people out of the way who keep threatening access to care in our communities. So
Mhm.
it's been a wild ride for me. It's very powerful work. It works that drives me every day, but it's also very difficult. I never thought
Yeah.
I'd be an entrepreneur. I never thought I'd be a business owner. So there's so much I'm learning along the way, but this journey has been incredible, and I wouldn't give it up. So that's what we are. We're the sacred space for Black women's health and wellness. I mostly see Black women, but I see everybody. Of course, we know that it is painful to discriminate, so I never discriminate. So I have brothers here, I have white folks, I have brown folks, I have all kinds of people that come here because they recognize the quality of the care that we get.
That's so amazing. That is so amazing. And it makes me feel important. Being a nurse, because I've been a nurse and a patient. So I see it both sides. So that's amazing, Dr. Cooke. I
Thank you.
love that for you and your practice and your patients.
Thank you. Yeah, I had to call it out because I feel like it's so funny. You guys probably hear this too. When people say they're looking for a doctor, the first thing they say is, you know any Black doctors? You know any Black women doctors, right? So I was like, let's just be that spot. Like let's say it unapologetically that we are the space for Black women's health and wellness. That's what we do. And some of these spaces exist, but I find that a lot of places dedicated to Black women's health really focus on, I think, the negative aspects, that we're poor, that we don't know any better, we're uneducated, we have to have these very low level services for these poor women that just need all this help. And that's not all of us. There's plenty of us who are educated, have a little income, but still need to be treated with dignity and respect. And that's really what my practice serves.
Very. So thank you for that, Dr. Cooke. We really want to get into hormone replacement therapy as it relates to GLP-1 medications, since we're all on GLP-1s, right? And it's something that we hear a lot about in the community. And for a lot of us, we're just unsure of how those medications relate and how they can help us. So if you're able to speak on that, that'd be great.
Absolutely. So let me first say, again, I love what you all are doing with this podcast. For any physician who dares to come on this podcast in the future, you be careful working with these two nurses, right? Because you sent me a list of questions about what we're talking about today. And usually when I get podcast questions, it's, tell us about your practice or why did you get into medicine? No, these ladies are like, let's talk about the indications and contraindications of this therapy. What is the mechanism of action of? I'm like, oh my gosh, I have had board questions easier. Y'all came like you are not trying to play, and I love it. I was like, I got to take some extra notes. I know my stuff, but maybe let me double check. It was hilarious. So thank you for coming so prepared. So if you're listening this far, like stay tuned because we're about to get real. Like they
Yes.
and we are not playing right now. So I just have to share that because you all are amazing. So we're gonna get into more of the details, but your big question is GLP and hormone replacement therapy.
Yes.
I think we have to take a step back from that because what we're talking about really is obesity and hormones, like obesity and menopause. And there is a super, super, super strong relationship there. So I'll say I am almost 40. So I'm not quite in my 40s yet, but even as a 39-year-old, I'm already starting to have some symptoms of menopause. And we've learned that women can have menopausal symptoms as early as 35, as early as 35. And who are the women that are more likely to get those early menopausal symptoms? Of course, it's Black women, right? Many of us start our cycles very early, like we're only going to menstruate for so many years. So if we started at 9 or 10, which is kind of early, and a lot of us have, we start getting menopause symptoms a lot earlier than other women. So the studies overlook us, or us Black women go to doctors, and doctors it may not even be on their radar that this 35-year-old, 36-year-old, 37-year-old is having menopausal symptoms. So with menopause also comes this really tricky thing called insulin resistance. And that's kind of the backbone of metabolic disease, of diabetes, of all those different things. And when you're insulin resistant, it is very difficult to lose weight. In fact, you start to gain weight. And you gain weight in the worst area, right? It's usually right that belly fat around your central core. That's where the weight shows up. So you may have some women who've been very fit, very trim for most of their lives. They hit 40, early 50, and you're like, where on earth did this belly come from? Like, I'm not doing anything different. I'm not eating any differently. I'm working out the same. I don't understand why I'm picking up this weight. And that's because the hormonal changes that come with menopause can cause that insulin resistance. And GLP medications are designed specifically to help overcome that insulin resistance and help us with weight loss. So there is a beautiful relationship between the two. And I do like to see this combination in my women who've been struggling with weight and who are facing menopause.
You have questions?
So I do have a question. When you talk about insulin resistance, and GLP-1 medications, we know that GLP-1 medications make you more insulin sensitive, right? So I have heard, just in coaching, patients talk about their clinicians, and I'm not talking about patients with obesity. I'm sorry, patients with diabetes. So about patients with obesity who have said to me that my doctor has offered to put me on metformin, to complement the GLP-1 in hopes of making me more insulin sensitive.
Right.
How does that work for an obese patient who does not have diabetes?
Absolutely. So great question. So insulin resistance, the biggest thing we connect it to is diabetes, but it's not just diabetes. We see it play a role in obesity. We see it play a role in heart disease. There's all these different pathways that insulin resistance impacts. Another big area we'll see it is going to be in PCOS, right? Polycystic syndrome. So women, and again, that's a hormonal issue. That's not a menopause issue, but it's a younger women's hormonal issue. So insulin resistance is very tricky and plays a role in a lot of different processes that regulate our health. Metformin was probably one of the first medications we've had that specifically addressed that. So I'm definitely a lover of metformin. So metformin for the longest time was one of the only agents that we had to help diabetes. It's one of the oldest. It's one of the best. Does it have limitations? Absolutely. Are there some people who do not do well on metformin? Absolutely. The biggest side effects you're going to see are things like GI side effects. People get the bubble guts, they have diarrhea, like feel pretty bad for some people. That's not for everyone. But metformin had long been considered the first line medication if you have insulin resistance or diabetes. And we use it off label for obesity. I don't think it's ever been officially FDA approved for obesity, but we do see some people by correcting that insulin resistance help lose weight a little bit better. So I do have some patients who've been hesitant to start GLPs or can't get insurance access or can't afford metformin, and they're using that as one of their weight loss mechanisms.
So if I'm educating during my coaching a patient who is taking metformin with their GLP-1, what is something that I need to make sure that we understand with them being the patient taking metformin? Because for me, I always go to the drop in blood sugar, like the mechanism of action for the metformin, because a lot of obese patients who don't deal in diabetic medications don't understand that the mechanism of action will drop your blood sugars. So that's where I usually go. And I just want to make sure I'm doing the right thing.
Absolutely. No, thank you so much for asking that question. It's such an important question. And the answer to that is that it is actually incredibly rare for these medications to make you hypoglycemic or low blood sugar will require an emergency. And I'm so glad you brought that up, because that's one of the biggest concerns my patients have. So what I love about metformin, what I love about GLPs is that they help with insulin resistance, which is the most natural way to treat this process. I'm going to try to explain that a little bit better. There are some medications we give in diabetes where the only mechanism is just to drop the blood sugar. Like that's all it's doing. It's just like sugar's high, we're going to make it go low. No matter what else is going on in the body, we're just going to drop that blood sugar. So one is something like insulin. Like you give insulin, that blood sugar is dropping, right? Like that's just how it works. Another things are the sulfonylureas, which are falling out of favor, but those are pills that you take. You may have heard of glipizide or glimepiride. They just drop the blood sugar. So they're good for getting blood sugar low, but they do not correct the underlying mechanisms that led to that high blood sugar, insulin resistance. So when we correct that insulin resistance, the body actually just starts working better. The body's very smart. The body, like if you're working on insulin resistance, it kind of knows when blood sugar is high, it releases a little bit more insulin. And then when you hit the normal range, it stops releasing that insulin. So it kind of has its own thermostat to say, okay, we're where we need to be. We don't need to keep releasing insulin. So when you give medications that support that pathway, the body takes care of itself. So this is why we can give metformin and GLPs even to non-diabetic people without worrying about dropping their blood sugar.
You're on with two nurses that have a history background in cardiac. So we have a love for patients that we've taken care of. And of course, because we're all on the GLP-1 journey, we love to get your input on how hormone replacement therapy coincide with the GLP-1 medications in a cardiac patient.
I love it. So when I tell you all these very deep questions, right? Like this is a beyond board level question. And what I'll have to tell you is that we haven't studied this, at least to my knowledge, as intertwined as you're asking, meaning that GLPs are still fairly new. Like we're still waiting for a lot of data to come out. But I can tell you what we know about each of those categories: hormone replacement therapy and heart disease, GLP and heart disease, and what we can assume. Sometimes the studies will show us differently from what we assume, but what we assume can be the case when you combine the two. I'm going to start with hormone replacement therapy. I love that we're talking about this because this is the newest hot topic, because for years we have gotten it wrong. For years we have gotten it wrong. So there was a big study called the Women's Health Initiative that concluded in the early 2000s that essentially said that hormone replacement therapy is dangerous, that it can increase your risk of heart disease, increase your risk of blood pressure, breast cancer. And we really shouldn't be using these medications because we're going to cause more harm than good. When we went and took a second look at the data, we realized that all of that was wrong, that it doesn't really increase breast cancer, that the increase was clinically insignificant. And in the right patient, you actually decrease her risk of heart disease. So we denied women one of the therapies that was saving their lives. So hormone replacement therapy, what we're learning is not only does it help beat those hot flushes and those really annoying symptoms that we get from menopause, but it can help us from a cardiovascular perspective. It actually can help prevent dementia. A lot of women go through menopause and get brain fog, and they're like, I just can't think the same way. Like, I'm forgetting things. I walk into a room, I have no idea what I'm doing. And there's a suggestion that those are early stages of menopause. And we think, of dementia. And we think about a dementia patient, you usually think about a woman, right? If you think about dementia, it affects us much more than it affects men. Because with us living longer, sometimes our bodies outlast our brains. And putting that extra hormone back in can help protect our brains. So I say all that to say we could have a whole topic just about menopause replacement therapy or hormone replacement therapy, because it can be so critical to the health of a woman at every stage of her life. So really, really important care. So going back to the cardiovascular piece, we know that for the right woman, meaning a woman who hasn't had a heart attack or stroke before, a woman who does not have a strong family history of heart disease, a woman who doesn't have a history of blood clots, she can usually safely take hormone replacement therapy. And if she starts it within 10 years of her menopausal journey, so earlier is better. So we're talking about putting women in their early 40s, early 50s on this, not waiting too long, which is what they did in the Women's Health Replacement Study. If we start early, we actually help her prevent those heart attacks. You all may have heard that as women go through menopause, for some strange reason, the liver changes. It starts making more cholesterol. So again, these ladies have gone to their doctor every year, had a cholesterol check, and then they hit 45 and bang, their cholesterol is skyrocketing. That's sometimes a menopausal effect. And we correct it with the estrogen. We see those cholesterol levels get better, which means less heart disease. So amazing outcomes we're seeing when we put women on hormones, like we see them actually improve their heart disease. Now, when we talk about the GLP side, you guys also may know there's some amazing data about the GLPs. Wegovy specifically was approved to reduce cardiovascular risk events. So you may go to your cardiologist and get put on Wegovy. So like,
I love it.
Yeah. Like, I don't know why my heart doctors put me on this weight loss medicine, but separate from weight loss, they looked at Wegovy and saw that people had fewer heart attacks and fewer cardiovascular death events when they were on medications like Wegovy. So at one point we mentioned how insulin resistance is not just a diabetic problem, like it has heart implications. So using these therapies actually help decrease heart disease. Now, I don't know that the study's been done that says if you use hormone replacement therapy plus GLP, you get even more benefit, but you can almost assume, you have to be careful with medicine with assumption, but you can almost assume that if you're doing these different tactics to help decrease heart disease, that we will have some outcomes where we're going to see lower heart disease, lower heart attacks, lower strokes.
So Dr. Cooke, how does that affect women who are battling breast cancer or cervical cancer or any type of cancer that I think that what I want to ask you is, for me, because I had breast cancer, I can't do hormone therapy, right?
Right. So that's one of the contraindications. So if you've had a history of a cancer that is an estrogen sensitive cancer, so we're talking about breast cancer, we're talking about endometrial cancer, those are the two main ones. Cervical cancer actually doesn't fall under that. So a history of cervical cancer doesn't preclude you, but breast cancer and endometrial cancer definitely. Just because many of those cancers are fed by estrogen, and we want people in remission. We don't want their cancer to come back. Every now and again, little cancer cells are floating in the body, and your body's system will take care of it. They're like, you don't belong here. We'll fight you off. But if we put you on a therapy that could be feeding those cells, we could be bringing those cancers back. So in women that have had a history of breast cancer, unfortunately, we can't use hormone replacement therapy. It does not mean that there aren't things that you can do to protect your health. Because just like with GLP medications, I'm sure you all know this, you can't just take the medicine and expect magic to happen. You have to be working on your diet. You have to be doing your exercise. You have to be controlling your stress. So with women's health, all those things matter too. Are we getting enough sleep? Lack of sleep more brain fog, more dementia, right? So even though you may not be able to use hormones to prevent your dementia down the line, there's other lifestyle things you can do that can help close the gap from the lack of hormone therapy that we're using. So excellent question. The other thing I want to kind of go back on, because yes, if you've had breast cancer, endometrial cancer, you can't take hormone therapy, but breast cancer and endometrial cancer, you're much more likely to get them if you are dealing with obesity, right? So the heavier we are, the more estrogen our body makes, it starts feeding those cancers. So if we talk about that woman who's in her 20s, who's carrying all that extra weight, by the time she hits her 40s and 50s, her risk of breast cancer and endometrial cancer is a lot higher. But if we gave her a GLP back then, right, try to correct some of this obesity, we can actually reduce a lot of these cancers. So breast cancer, endometrial cancer, I actually believe there's a relationship with colon cancer. So there's a huge connection between cancer and obesity that we're learning a lot more about. So by correcting obesity, we can prevent these things in the future.
Thank you.
Wow.
Thank you. Excellent question.
And I was thinking along the same lines when you said having a stroke. I'm like, because I'm 46 and I feel a little brain fog right now, you know?
Right. So the hormones can help. Of course, we can't use that with your history, but that means you got to go extra hard with the lifestyle, right? Like you cannot compromise on that 8 hours of sleep. I love that y'all say healthcare hustle, but we can't hustle too hard, right? Sometimes we're into this hustle, 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 no sleep till I'm dead. And those things can really backfire on us. So I got to make sure my ladies are getting their full night's sleep. I got to make sure they're eating a healthy diet. And I'm sure you all talk to your patients about this, like what you put in your body matters. And if you want your brain to work optimally, like it can't be on junk all day. Because if you're body with junk, your brain is not going to think so well. But if you have all those nutrients, you're not letting your blood sugar get too low, like you're gonna work much more optimally. So there's still a huge role for lifestyle intervention to help prevent the brain fog and to help prevent things like dementia and heart disease.
Perfect.
And Dr. Cooke, can you circle back to the mechanism of action for the metformin? I just want to be clear on that because, again, I have a lot of patients who doctors are supplementing their GLP-1 with metformin, and I just want to make sure that I am doing my due diligence in educating when they ask.
Absolutely. So metformin, the mechanism is it improves insulin sensitivity and it also decreases your liver from making sugar. So I think it's a good question. I'm glad you're going back to it. That your body has all these mechanisms with its own thermostat, that thermostat that regulates blood sugar. When your body needs sugar, it starts releasing it from your liver. It releases it from your fat, from your muscle. When it doesn't need sugar, it turns those mechanisms off. So that's the pathway of how we keep our blood sugar normal. As we get more insulin resistance, that insulin isn't working as well, those mechanisms don't work very well. So when we correct that with things like metformin, with things like GLP, we make that thermostat work again. So we're not going to drop the blood sugar because the thermostat is now working effectively. So you can safely give GLP, you can safely give that with metformin and not worry about a low blood sugar because the body's working the right way. Now, where you do have to be careful is if you're doing a GLP plus insulin, there's not a lot of people that this applies to, but I do have some patients whose diabetes has been so far out there that I do have them on a GLP and insulin. Insulin, as we mentioned before, no matter what's going on, like this is not thermostat dependent, it is just dropping the blood sugar. So if you're on a GLP plus insulin, you got to be very careful about that blood sugar. They have to know how to check. A CGM monitor or continuous glucose monitor would be very helpful for those patients because they are at risk of having a low blood sugar. The sulfonylureas, the glimepiride, the glipizides, those, they just drop the blood sugar no matter what's going on. It's not dependent on that thermostat. So with that medication, you do have to be very careful. But GLPs and metformin, extremely unlikely that you're going to get a critically low blood sugar. Nothing's ever impossible, right? So if you're taking both and you're not eating, yes, like we could get into a lower volume or lower area. But remember, those body's other mechanisms start to work better. They'd say, hey, liver, there's not enough sugar in the body. Can you make a little bit more? Hey, muscle, not enough sugar. Can you make a little bit more? So your body should correct that low sugar. So yes, you can safely use those together without worrying about the blood sugar getting too low.
Wow. So patients don't need CGMs with metformin.
I don't want to say they don't need. I think it's helpful, but I think it's helpful just to kind of regulate what's going on. But the risk of having that low blood sugars is extremely low. What I like about the CGM, what I like about the CGM is I think it's a great tool for patients to get feedback about the way food affects their blood sugar. Patients, I'll tell you one story. I had one of my patients, and she's an elderly Jamaican woman, and she just knows that her what was she drinking? It was like cranberry elderberry juice, right? So she had this cranberry elder, and this is her tonic. She was like, this is what keeps me healthy. And her blood sugar A1C was like 12, which if you all don't know, the A1C is
Gosh.
high. She's refusing insulin. Like she's just that patient that I
Okay.
love her to death. I'm like, you got to stop drinking this juice. But her culture is like, no, I need this elderberry cranberry juice. And so we got her a CGM, a continuous glucose monitor. She put that sucker on. She had her cranberry elderberry juice and watched her blood sugar shoot to 300. And she was like, oh my gosh.
Mm-hmm.
Like evidence of what was happening. And she's like, oh, I didn't realize how much it was actually hurting my sugar. And so it helped her change her behavior. Because I was like, there's no way we're going to get this woman control without insulin. But when she saw that feedback, she cut back that juice and we got her A1C to 7. No
Wow.
medication. That's with that feedback. So is there ever like a need for CGM? I wouldn't say there's like a perfect, like somebody has to have it. I do think if you're on medications that can drop your blood sugar, it's very helpful. But even if you're not, it can give you really useful feedback about how the foods that you enjoy might be raising your blood sugar.
Mm-hmm.
I'm so glad that you said that, Dr. Cook, and had an example because I was just having this conversation 2 days ago with someone that loves to eat carbs at night. And I said, I think if you get the CGM and you get this information, you'll determine that, you know what, I don't like the way my sugar is looking. I might need to cut back. I said, I think that would be convincing enough for you versus me, trying to provide you this education.
Mm-hmm.
But I want to ask a question, what would be like the typical plan of care for a patient on GLP-1 medications that also takes insulin and metformin? How will you titrate that person off of the insulin and metformin?
Very good question. And I'm going to circle back for a minute because I have to take this opportunity to talk about CGM again. I love the CGMs. And you know how I feel about, and you know how I feel about the insurance market and just the way that insurance dictates what we get. A lot of times CGM is not available for people unless they're on multiple shots of insulin a day. It drives me nuts. So if I try to write a prescription, they get denied all of the time. But now what I love is they're becoming more available on a cash pay basis. We're so committed to this. Like I use my insurance for everything I do in my healthcare, but using cash can actually get us great access to things that can change our lives. It
Mm-hmm.
drives me nuts that insurance says, no, if they're not on insulin, they can't use this tool. But here's this one patient that took a CGM. It's not super expensive, a lot better for her than taking insulin, and we corrected her diabetes. So when I say sometimes the interference of insurance can sometimes harm the healthcare relationship, these are the things I'm talking about.
Mm-hmm.
So I want to just open people's eyes to like, it's okay to spend a little on yourself and to invest in your health because this investment that this woman made allowed her to get her blood sugar under control without having to use more advanced or aggressive therapy.
Wow.
So just a little plug for like cash-based economy when it comes to healthcare. I
Mm-hmm.
think it's important to keep these things in mind. Like don't let insurance say you can't have this. Let's look for a good cash-based price. So you again asked another one of my nurse level questions of how do you titrate somebody that's like insulin and GLPs and metformin. So I'll see if I can try to start with an example. The GLPs again are fairly new in the market when we think about just medical therapy. Like I have been a doctor forever, right? I've been practicing 10 years this year. And when I started practicing, GLPs were really not a thing. There was a couple out there like Byetta, Bidurion, like they really weren't a thing. So it wasn't anything I ever trained on. I say that to say that most of what people had been using for their diabetes for years had never involved GLPs. So when these medications became available, you do have to start changing people. So my go-to was always metformin. Everybody got metformin unless you couldn't tolerate it. So everybody started there. If they weren't doing well on metformin or not reaching their goals, I'll add another agent. So that could have been like an Actos, or it could have been what else did we have? We didn't have a ton of options, but the options have really blown up lately. But when GLPs came around, they really changed the game. Like when I started using Ozempic and I was having these patients that I was struggling for years to get them under control, and I saw their blood sugars normalize and they weren't getting low blood sugars. I didn't have to worry about, their blood sugar dropping at nighttime anymore. It was incredible.
Yeah.
So typically, if I do have a patient that's on insulin and on metformin, if I start a GLP, I'll sometimes keep the metformin there because I do like that double effect of making you more insulin sensitive. But I often will drop the insulin by a little bit, depends on what they're on. So I might drop it like 10, 15%, put them on the GLP at the lowest dose. As you all know, with GLPs, we slowly titrate up that dose. My goal as a physician, for me at least, is always to get them off of insulin. I try to control their diabetes with the GLP exclusively and not insulin. Insulin is not a bad drug, but it's not a pretty drug either. So when we need it, we need it. It's one of the best things to lower blood sugar. But as you all may know, the more you use insulin, like we're not correcting the underlying issue, we're just dropping sugar. And we also contribute to weight gain, right? So if I need it, I need it. But now it's my last resort because I have better options. So my goal is always to see if I can get my patient well controlled without the insulin. So I start them on their GLP. They may have some insulin, but I'm going to drop it by about 10, 15%, put them on that starting dose of the GLP. Let's see how they do. Sometimes they correct almost completely, and I can drop that insulin by half or 100%. But suffice it to say, every time I increase that GLP dose, I see how low I can get my insulin dose, and hopefully I can get it off altogether as long as their A1C is responding. I have had a handful of patients that I've maxed them out on their GLP and they still aren't at goal, in which case I need to use that insulin as well. So I try to say it carefully. I don't want people to look at insulin as a failure. You know, if you need to do it to control your health goals, that's no big deal. But it shouldn't be the first line of what we're doing. Yeah. You know, like if we need to use that tool, so be it. But if I can kind of get you control without that tool, we can get rid of it. The metformin, you know, has a different mechanism of action of the GLP. It does increase sensitivity. It makes your muscles more sensitive to insulin. It helps with your liver. It helps all these different processes. So I like to leave the metformin on there as long as my patient doesn't refuse. I have some people who are like, Dr. Cooke, I just want to get rid of these pills, right? Like I'll take a shot a week, but I don't want to be on this metformin anymore. So if they just want to get off of it and their blood sugar is controlled, I won't fight it. But if I can keep it together, I do like that synergy.
Yeah. So Dr. Cooke, for a obesity patient who is on GLP-1s and they are not seeing the results that they feel like they should be seeing, when would you implement metformin? If you would implement metformin, when would you do that for an obesity patient? And is it appropriate?
Good question. So I think the bigger question is it appropriate? When you all talk about your counseling with patients, you can go so far with GLPs, but there is kind of a limit of how far we can go. So if we look at the data, we're seeing what things like Mounjaro and Zepbound, which is tirzepatide, you know, the same medication, just under different brand names. With that medication at maximum doses, we're seeing about a 25% drop in weight after about a year of use. That's incredible. That's incredible.
It is.
Let's talk about that patient who's 300 pounds, right? So if you're 300 pounds, a 25%, I cannot do simple math, but that's going to be about 60, maybe 70 pounds, right? Is that right? Like 25%, I think is 70. Yeah. If I do it in my head really quickly. So for that patient that went from 300 to 230, that's incredible weight loss. But to get them to where, like, let's say that their ideal weight, which is, you know, not a perfect measure, is around 180, you know, 170, 180, we're still not there. We still have a gap, right? So we have to be realistic about how much weight loss we can get out of these medications. I'm going to step back for a second and say, as long as you lose 10% of your body weight, even if you lose no more, you have corrected so many metabolic issues. So it's not about getting to this teeny tiny goal that you're aiming for. Like just losing 10% is where we see the biggest health benefits. Going beyond that doesn't really get us more health benefits. Now we may look a little better or we're happy the way our genes are fitting, but you don't necessarily increase the health benefits by continuing to lose that kind of weight. So we're talking about a 25% drop in weight. So you have to be realistic about how much weight people are going to lose. When people have probably more than 50% body fat to lose, we have to talk about bigger tools. So we have to use the right tool for the right project. I heard a doctor once say, you know, could you imagine if I grew up in Boston where we had snowstorms? If you had a snowstorm and you had to shovel your driveway, could you imagine if you took a spoon out there to shovel it, right? Like that spoon, you ain't going nothing with that. Like, yeah, you lose snow, but there's nothing to do with that, right? Your spoon is your metformin. Right? That's your metformin. So it's like, it's going to do something, but you have a huge job here and that spoon is not going to take care of it. Now your shovel is going to be your GLP. Like you can do some work with that shovel. You can clear the whole thing. It's going to take a lot of work, but you know, you have a shovel and it's going to get you somewhere. But then your bariatric surgery, your sleeves, your gastric bypass surgery, that's your plow, right? Like that's going to help that's going to be the right tool for the job if you have a lot to clear. So if somebody's struggling and they still can't get that extra weight off, I'm not so much talking about metformin. I'm talking about, do we have to bring out the bigger guns, the more effective project, which is probably going to be talking about bariatric surgery.
Gotcha.
So surgery is the bigger tool, but I will say what I'm more likely to do, I might add that metformin, but I might even go back to one of your oldies and goodies and phentermine. You know, so if they're like, look, surgery is a big deal. It is. I'm not going to say, oh, just go get surgery. That's I don't want to say that nonchalantly. But sometimes adding that sprinkle of phentermine can help people get past some of those plateaus that they hit. So I have hit a plateau on a GLP, and that's where I'll pull out something like a phentermine, and that can help me get a little bit further. So phentermine is like another form of a shovel. It might be a smaller shovel. It's bigger than the spoon that metformin is, but it's a smaller shovel, and that can kind of help them along. So that if I do a medication add-on, it's probably going to be phentermine. If they need more help, we're going to talk about, do you need to see a bariatric surgeon?
Are you concerned about phentermine with your cardiac patients? I mean, I know that you are. I don't even have to ask you that. I know that you are. But for patients who, you know, there are a lot of patients, they don't even know they have cardiac disease. I've coached a lot of patients who don't even know how to recognize what cardiac disease is. Some people think, oh, I have high blood pressure only when I eat salt, or they have all these rationales and they don't know that they have undiagnosed hypertension, or they know that they have it, but they don't know the importance in getting it treated. And I'm saying that because we have a lot of them that come through the emergency room and they don't even realize how detrimental it is to take care of cardiovascular disease. So when I'm coaching, I said all that to say when I'm coaching, I'm very careful about talking about phentermine because of the palpitations that come with it and all of the things. So I try not to even, as a nurse, even bring it up because I just don't know if patients know what to do with a phentermine and how to get their follow-ups and take it serious about going in to see their clinicians to get their checkups to make sure this medicine isn't, exacerbating something that's there that we're not already taking care of.
Exactly. I love that you said that. And I think if you're uncertain, because it is a good conversation with your doctor, and you're going to get different answers from this. You're going to say some doctors, heart disease, hypertension, hell no to phentermine, we're not doing it. I'm a little bit of a rebel there. I'm willing to push the mark a little bit further because to me, this becomes a risk benefit analysis, right? Person has cardiovascular disease and they're carrying 50 extra pounds. They've done all the things to try to get it off, right? This obesity is probably going to hurt them faster than the phentermine will. So I'll be a little cavalier there and I'll give them a lot of warnings and say, look, this medication can cause palpitation. It can increase heart rate. Your EKG looks good. Let's try a low dose and see how you feel, right? Let's try low dose, how you feel. And so we'll put them on a low dose and we drop some pounds. Maybe I can even lower some of their blood pressure medication. So I'm helping them get metabolically healthy. Even though this may not be the safest way to do it, like I think you can have a good risk benefit conversation. So for many of my patients, they can actually tolerate phentermine pretty well, even at high doses with a risk of hypertension with a risk of heart disease. But I watch them like a hawk. Now, the minute they start having complications or they're having palpitations, the great thing about it is you stop it and the effects are out of your body pretty quickly, right? It's not a long-term thing. It doesn't reverse pretty fast. But for me, I'm willing to try it. It's almost like those patients who, there's some doctors for a long time who are very against bariatric surgery. They're like, no, you're so obese, you're so overweight. Surgery is so dangerous. It's so dangerous. Well, at some point in your life, carrying that weight is more dangerous than the surgery is. And so you just have to make a risk bet. Like there's no way that you're going to go without risk. But for that younger patient, if we correct their obesity now, how many years of life do we give them on the back end? So, we took a little bit of a risk here. We can't say there's not a risk, but that risk was probably worth it. But to say, oh, no surgery for you because it's too risky, and now they're having a heart attack or stroke at 40, like was that the right risk to take? So I do think it's a delicate conversation. I think you can have that conversation and say, this is an option, but you have to talk with your doctor about whether you're an appropriate candidate. It could worsen heart disease, but so I would be careful with that conversation, but I would never say never to that because again, it just is a bigger conversation about the risk and benefit.
I did have one last question. I feel like the conversation have been centered around GLP-1s and women. What about men when it comes to hormone replacement therapy? Does that affect men and GLP? Is that a correlation? Is there a correlation there? Hormone replacement therapy in men or no?
Gotcha. So I would say this is not where I have the most expertise. I still treat men. So do men experience menopause the way women do or some type of hormone equivalent? That's a controversial topic. There's some people that say that men go through something called andropause, androgens meaning the hormones that men have like testosterone. And they think that there's a related syndrome that they go through. It's not quite the same. And there's, if you ask different people, they're going to give you a different answer about whether this is a real thing or not. I do think that there's some validity to it. As men age, sometimes those testosterone levels drop. Lower testosterone can mean less muscle mass, all those things. So they can start to get more weight. They can start to get more obesity. So some men that start testosterone replacement notice that they get, more muscle mass, easier to bulk up, easier to shed weight. There's more controversy about when you can start hormone replacement therapy for men. So the cutoff for starting by FDA regulations for starting hormone replacement for men is pretty low. Like you have to have almost no testosterone to be able to qualify for testosterone replacement. The tricky part is for those men who are like low normal, right? It's like, the range is this big. You're hanging out on the normal side, but you're low normal. Could you benefit from a little bump and a little extra testosterone? Maybe you could. But then the other side of wisdom says the other thing that improves testosterone is exercise and weight training. So if they start doing more resistance workout, if they start shedding some pounds, they can raise their testosterone naturally. So if I'm treating a man, I would probably start with the GLP to help his weight loss journey, help him start doing more of that resistance training and seeing if that will naturally boost his testosterone rather than giving him exogenous testosterone. I'm not
Mhm.
above doing that, but again, if we can try to go the more natural route, that's always the preferred route. But if that's not getting us to our goals, then we can certainly incorporate hormone therapy as well.
Wow. Thank you.
Yeah, so more controversial. We're still seeing more data come out about that, but it's been very popular in the men's health space, like treating low testosterone. Like there's that team that's like, put everybody on testosterone, they're going to feel so much better. But there are some risks to testosterone, like the roid
Mhm.
rage. There's some bad things that happen if you overtreat with testosterone. So you have to be very careful. And then you have that camp that's like, no, boost it naturally, do more weight training and resistance training, and we'll get the testosterone levels up. And so, as usual, I kind of fall somewhere in the middle. Like, let's try natural, but if not, we can certainly use Western medicine to help us further our goals.
I wonder if men know that by working out and getting their muscle mass up, that helps their testosterone.
If
I
they
never.
don't know, some of them don't want to know, right? Just like some of your patients that don't want to eat better but want the shot. They don't
Yeah.
want to know that there is some work that's involved, and that's okay. And a lot of times, if they do that work, they feel better, right? I'm sure you tell your patients all the time, like I'm gonna say no one never wants to do a workout, but those days that you dread your workout, you never regret it. Afterwards, you're like, man, I
Mhm.
should have done this, dude. I feel so much better. Like, it releases your stress and tension. So the things that are good for us help us feel good. And
Mhm.
we sometimes don't want to do them because we feel like it's so much work. But when you get into those little habits of doing the little things that help you feel better, you just feel better. So I
Yeah.
do want men to know that, but I think sometimes this idea of like, oh, I don't want to, lift weights and work out. I just want to bulk up without, but that's
Mhm.
not
The moment that I start educating with GLP-1 medications, I still go back to lifestyle changes, lifestyle eating, and exercising. And when I give examples of things you can do, whether you work from home or not, I hear this dead silence, like
realistic.
cricket. I'm like, okay, I've hit a sore spot, and say, oh, I can't do this or I can't do that. And I'm like, well, you have yoga. It's really light.
Mhm.
We have,
Mhm.
we have so many resources that make it so easy for you. These walking pads, counting steps going from upstairs, downstairs, and all the things. And they're like, okay, Kima, see you next time. The conversation is cut off.
Agreed. And I think some of that's that people don't want to do it. But what I find more often is that we have these unrealistic and almost toxic relationships with exercise. Sometimes if you're on the TikToks and the Instagrams, you're seeing these people go hard and they're doing these crazy gym works out. And I feel like people think if they're not doing that they're not exercising.
Mhm.
So I try to set the eeny, meeny, little tiniest goals with my patients, and it cracks me up because I'm like, well, what can you do? Can you walk to your mailbox and back? Can you walk around the block? And they're like, yeah, I can do that, but that ain't gonna do nothing. Doing something is more than you're doing right now, but there's this
Right.
idea of like if it's not 110%, it just doesn't count, right? And so I
Mhm.
really try to educate of like, even if you're not in the gym working out, using a standing work desk and not just sitting all day.
Yeah.
QB and cycling for a few minutes, watching TV and getting up and jumping jack for a few commercials, like those little things add up. But in the back of our mind, we feel like, oh, it's just so small, it's not going to make a difference. But
Mhm.
it's kind of like on the opposite end, like that one piece of candy every 2 hours that you've been getting at work, like you see the difference that makes in hurting your weight
Yeah.
loss. Even just adding these little pieces of exercise and lifestyle can add up in the long term to really help meet your overall goals. So I really try to tell people if you like to do the hardcore workouts, by all means do that, but you can still be healthy and never do those hardcore workouts. A walk is enough, just standing is enough, just getting off your couch is enough, putting on your YouTube video and dancing for a few minutes,
Yeah.
like all of that counts. And when you make it realistic and help them understand that even the little bits go a long way, I think it can help. But yeah, we dismiss the little parts all the time.
Mm, absolutely. Well, we're coming to the end of this segment. So, Dr. Cook, I want to thank you so much for
So much.
lessons and the education. I love it. Yes, I do have this relationship with you as my doctor, but
Mhm.
I see what you're doing in the community and I love it. So I'm going to always support you in any way that I can.
Thank you. Thank you. And I definitely support what you all are doing. Thank you for being a voice for women and talking about these medications because we're helping women not only just overcome obesity, but like you said, the heart disease. Because what's the number one killer of women? It's this heart disease.
Mhm.
So there's just so many things that you help in their lives by going on this journey. So I love your transparency and documenting your journey, showing that it's not perfect every day. There's some days where like, I think Kima said, look what I ordered. Like I ordered all the candy and all the you have a down day. And I love that you've made that transparent. So I really appreciate what you do. Thank you for including me as a part of it. I'm happy to come back anytime. Maybe we'll have to, tamper down the intensity of the questions or make you guys write some board questions because these were real questions out there. I loved it. I loved it. You definitely challenged me this morning. So thank you again for doing what you do.
Dr. Cooke, tell everybody where they can find you on social media. You know, this is a social media space, honey, so people be wanting to do their little scrolling. So where can we find you on social media?
Absolutely. So my biggest platform is definitely TikTok. So if you look up Dr. Michelle Cooke, and I do have to say Michelle has 2 L's and Cooke with an E. So Dr. Michelle Cooke, all one word on TikTok. You can also find me on Instagram and on Facebook by the same name, Dr. Michelle Cooke. My practice is Soul Direct Primary Care. Nothing can ever be spelled normally, right? So Soul is S-O-L, not S-O-U-L, not S-O-L, S-O-L. S-O-L is the Spanish word for sun. Believe it or not, I was not a science major in college. I was a Spanish major. And my love and Spanish language, that's a very big part of my life too. And so I love the idea of soul and bringing that imagery into the practice. So it's S-O-L, Soul Direct Primary Care. If you follow me on social media, I talk about you being my soul sister. So that's my play on words. So you'll hear me reference that quite a bit, but that's where you can find me.
We'll definitely get your information correct in the description.
Thank you for that.
So you guys, I hope you have found that to be very informative with Dr. Cooke.
Okay? That was an amazing interview. That was so much fun.
Make sure y'all follow Dr. Cooke because she is definitely here for the ladies. Okay. Yes. And the gentlemen as well.
Okay, guys. So let's get into some hot topics. Nurse Kima. Now, listen, this clip was sent to me by my husband. Okay. Surprisingly, for those of you who don't know, my husband is also on his GLP-1 journey. Now he's taking it because he's a diabetic, but he sent me this clip with Shaquille O'Neal and Charles Barkley having a conversation. So let me play this clip for you, Nurse Kima, and tell me what you're thinking about these jokers.
Okay.
Here we go.
You all right, big fella?
Yeah.
Okay. I'm gonna lose some weight. The chair won't break.
Well, I'm lighter than you, fat.
You ain't lighter than me, you fat ass. You ain't lighter than me. Get on the scale right now. Get on the scale right now.
Just because you taking Monfuro or whatever the hell you taking.
Manjaro.
Yeah, whatever.
Hey,
you taking Manjaro? What is that?
It's a drug.
Yeah.
You taking a drug?
Fat boy.
Oh, no. You taking a drug.
It's that diabetes
No,
drug.
yeah, but
You have diabetes?
I know, but everybody's using it for weight
everybody.
loss.
You know the drug you need to take? It's called this. You get out there and you do a little of this and you do less of this.
Exactly.
And less of this. That's the drug.
So what I was saying.
Oh, you cheating the game.
I'm not cheating. No, people cheat the game on Ozempic. You can't even spell Monjaro. Spell it right now.
Girl, those fools. Oh my goodness. First and foremost, I wanted to say, now I know that they were just joking with one another. I know that they are having a good time. They're having fun. And I know that they take this medication very seriously. I did know that Charles Barkley has been on this medication for some time. I've been seeing clips of him for a year now. And he has fared well on his journey because he looks really, really good.
Yes. So let me just, first of all, for the people in the back, I'm just trying to figure out why everybody is so stuck on Ozempic as if Monjaro is not king. Hello. I mean, where you at with it?
I think Ozempic is just a hot word. Even when I am doing content, instead of using Monjaro, for some reason my videos get more reach when I say Ozempic.
Oh, Monjaro is that girl.
I love tirzepatide.
Exactly. I mean, like, and I should not, in my mind, I'm thinking, who's taking semaglutide? I mean, who's taking that?
Now listen, don't get it twisted. If it come down to it, I definitely will be an Ozempic girl.
Sign me up. Sign me up.
Kima, it's one other thing I wanted to show you, girl. I came across this video. Now we both said that we wanted to strengthen our bodies for the new year. So I have a challenge for you, friend. There's a new dance trend that's out.
Oh Lord.
There's a new dance trend that's out, and I want to try it. I want to try it. But let me play this clip for everybody so that none of us are confused about what this dance trend is. Here we go.
Back, front, back. We're gonna speed this up. If you're not comfortable with clapping your ass, all I want is your hands. Boom, 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 boom. But if you can, get in that shit. Come on, 4, 3, good, 2, We call it the ribbit walk. You go ribbit, 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 ribbit. Staying low, lifting and dropping that ass. If you have no space, say and praise and lift up those legs. Santa sleigh. You go Santa sleigh, bring the gifts. 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 From the top, back, back, front, front, back. We're gonna speed this up. If you're not comfortable.
Oh, Kima. Oh my God, girl.
I'm ready. I'm ready. Okay.
Let's go. Oh my God. Baby, they bringing the gifts this year in 2020.
Okay. Back it up. Bring it in. Ow. We in there.
Oh my God.
Baby, we in
Girl,
there.
she look good though. And she look bringing them gifts, honey, because she look good. She look damn good.
Sure. Oh my God.
Oh gosh.
Listen, I'm so excited. I'm so excited. This health journey has been a booga wooga. We is in, friend. Would you have thought in 2022 when we started this journey that we're here now in 2025, we would be focusing on, okay, let's strength train. Let's go to the gym. Let's lift weights. Like I never would have thought I would be here in this space.
Yeah. Okay. That was so much fun. As we wrap up our third episode of Health and Hustle, I do want to acknowledge the fact that it is 2025 and that the new year came in with a big bang, no pun intended, for a lot of Americans. The American community is going through a tumultuous time. I want to refocus everybody's mindset and direct it toward God in everything that He wants for us. I want to play a clip by TD Jakes because I don't think I can say it better than what he can. So let me play this clip for everybody.
If you are in that crushing, I have been there physically, emotionally, spiritually, financially, in every aspect of my life. I want you to understand something, that whether the Lord scooped down into the ground and pulled up clay, or set it on a wheel and started spinning it, or pushed in on it with pressure and started squeezing it, that regardless of whatever stage it was always in His hand. And I want you to know that whatever stage you're in right now, you are still in His hands.
Amen.
To understand that no matter what it is that you are going through, God is here. He is in you. Focus on that. Let God have His way. Be the best person that you can be in your environment. Be someone that can encourage, someone who can pull someone up when they are down. Take care of yourself so that you can be a better you for the next person, and do the best that you can. Do the best that you can. If you need help, now is the time to get it. Help is out there. So there is a saying, when it comes to the things that you need from God, you don't have to tell the next man. You don't have to tell the person. You can tell He who is in you. But I just can't think of what the saying is. Do you know what the saying is, Kima?
You have not because you ask not.
You have not because you ask not. And it's not where you have to go and tell anybody your business. You can talk to God and you will feel His presence. He will tell you what to do.
Amen. All right, friends. So listen, I hope you all have enjoyed episode number 3, Nurses Notes by way of Health and Hustle with Ask Nurse Kima and Charge Nurse Keisha. All right. Bye, y'all.